Okay, so we've identified a movement that's dysfunctional and painful, and so Gary's going to demonstrate that. So we see flat spines, see 4 or 5 inches away from touching the floor, so we have a lot we can work on with that. Okay, perfect. Okay, so the first thing that we'll want to look at when doing a pelvic girdle exam for the motion palpation part. So we would assume that you've done your supine and prone palpation or seated. And so we'll get into the motion palpation part. And so the first one we'll do is that we'll find the sacral sulcus. And so on the female, it's going to be right around the dimples. For a male, it's going to be a little bit lower. And so what we'll do is we'll go around there and we'll find the PSIS on either side. So posterior, superior iliac spine. Go 1 step medial, 1 step inferior, and you'll be in the sacral sulcus. And so if we use the PSIS as a ledge, that we want to be just medial to that, but underneath it, so that if she were to lift her leg, this ledge will push my thumb down or not, depending on how she's moving. And so we want to be, if the PSIS is here and the sacrum is here, we want to be right in this spot so that we can feel the ilium move and we can feel the sacrum move, or the ilium move on the sacrum. Okay, so just from initial palpation, we can see that the left PSIS is higher, so probably a centimeter or so higher on the left. We can also look at iliac crest height, and iliac crest height is about the same. We would also look at pubic symphysis height. Usually when this is high and PSIS is high, then pubic symphysis will be high too. And that will tell us that she probably has an upslip. So pain and or restriction in 3 or more directions is considered an upslip or a downslip. Okay, so we're back to the PSIS. We're right in the sacral sulcus, right between the PSIS and the sacrum. And one thing that you can do here is just roll over the long and short posterior sacroiliac ligaments, and then you can also go to that connection of L5 to the ilium and roll over the iliolumbar ligaments. And she's actually must have had a long history of pelvic girdle issues because they're pretty ropey, so pretty easy to roll over. So sometimes they'll be puffy, sometimes they'll be ropey, but that'll tell you that the iliolumbar ligaments also been involved fairly regularly. We can palpate all the way down the sacrotuberous ligament, but I usually don't do that in standing. I usually do that in prone. Okay, so our first motion palpation test would be to lift the right knee towards your chest. Okay, and now lift your left knee towards your chest. Okay, and then lift your right knee towards your chest again. Okay, and left knee. So what we see is the right knee. So go ahead and do that one more time. The right thumb in normal motion should come back. Left should seem like it goes forward, because the one-legged motion, the hand should do opposite. And then when she lifts her left knee, left hip, then the left side should come back. So in this, go ahead and lift your right knee. Right side's coming back okay. We'll talk about what was actually wrong there. And then left side, not moving at all. So it's moving up and in. What's interesting about this is that when she goes to lift her right side up, even though it seems like it's moving properly, it's moving down, watch the shift onto her left leg, that she's really stabilizing extra. So try to lift that right leg. And that it's actually a kind of lateral or medial or diagonal shift. So she's got a dysfunction that is incorporating both of the ilia. Okay, So the March test will measure ilial rotation. And so the ilium should be able to move 5 degrees anterior, 5 degrees posterior for a total motion arc of 10 degrees. And you should be able to see that on your motion testing. And so what we would assume is she lifts the right leg, right PSIS comes back. She lifts the left leg, left PSIS comes back. And so we've identified that the right's not moving optimally and the left is actually the most dysfunctional today. It was actually opposite yesterday. So the right was more dysfunctional. And that's not uncommon. If you had a side of pain, which side would it be? Right side. And so usually 70 or 80%, in my experience, 70 or 80% of the time, the pain is on the opposite side of the motion restriction, meaning that the other side is trying to pick up extra motion. Okay, so the next test we're going to do is we're going to make sure that we're still on that same spot in the sacral sulcus, but make sure that we're kind of biased towards the sacrum on this, because what Carrie's going to do now is going to slide her right arm down her right leg. And what I'm feeling for is the sacrum to disappear or tuck on the side that she's bending to, and then come back on the side that she's bending away from. Okay, and then go ahead and do the other side. Okay, and so both of these have motion a little less than I would think is normal, but it's sometimes hard to tell without a history with a person.
Let's do that one more time, Gary.
So right side should tuck, you can see it tucking. And then as she goes left side should tuck, and you can see that tucking. I can definitely feel them moving. So they're not stuck, but they might not be totally mobile because of soft tissue restriction, meaning muscular contraction. Okay, next thing she's going to do, and so that will evaluate a rotation. From my experience, that'll tell us whether we have a rotated sacrum or a block in sacral rotation. Again, it's a one-sided motion, and so we're looking at uniplanar motion testing of the sacrum. Now, the next thing we're going to do is we're going to have her flex the spine, and then we'll have her extend the spine. And what we're looking for is to test for normal sacral nutation or counter-nutation. So nutation being flexion, counter-nutation being extension. And so as she flexes forward, we should see the sacrum counter-nutate or come back. And as she extends, we should see the sacrum, the base of the sacrum, flex. Okay, so or not. Okay, so we're in the same spot, right in the sacral sulcus, and now I'm going to have her bend forward as if she's going to touch her toes. And it's usually the first 15 degrees of the motion is the most important. And come on back. And so as she flexes, her sacrum should come back at me, and it didn't. It actually stayed forward. So that's why, one of the reasons why she can't flex her or she can't touch her toes. And now I'm going to ask her to extend, and she can't really, I can't feel that disappear, but it's probably because her motion looks okay, and so I probably don't feel it disappear because it's already forward, and so I'm not feeling it go forward because it's already there. And so as she flexes, the PSIS and the sacrum's not coming back at me like it should be, which means that it's stuck forward. And so it should be coming back, but because it's stuck forward, she's bending forward and not getting a sacral rotation, and then that's causing her restriction. And since I don't feel it going forward when she bends back, so opposite of the lumbar motion, as she comes back, I don't feel it going forward, but that's because it's already forward. And so her motion's okay, so that would tell me that would also reinforce the fact that it's nutated, forward bent or flexed. Okay, so
we're going to pause.
Pause.